I think ureteroscopy has a bright future because it is ultimately less invasive than a percutaneous surgery. So I think as we see more advances in retrograde endoscopic surgery, I think that we'll potentially see less need for percutaneous surgery, and that's coming from a doctor who does a lot of PCNLs. But I do think that that certainly is the direction things could go and probably will go. When you actually look at the anatomy of the kidney, you can look at certain factors that may make a case more difficult. This case in particular that I'm thinking of is a patient who had a pretty sizable stone in the lower pole but had narrow infundibulum, had a pretty acute infundibulopelvic angle, which means that to get a scope into that area is going to be challenging but not impossible. But there's certainly some approaches you can take to make that case more straightforward, if you will. This is a scenario where a shockwave therapy would really be not indicated. It's a stone greater than 10 millimeters in the lower pole. This particular case was a very dense stone. So that's a scenario where shockwave therapy should really not be offered, in my opinion. You can certainly opt between percutaneous surgery and ureteroscopy, but again, percutaneous surgery is a little bit more invasive, and this particular patient was more interested in a ureteroscopic approach. So we performed the surgery under a general anesthetic, but not a full general anesthetic, in an outpatient setting. So those are some appealing things to patients. I was able to place a scope into the lower pole of the kidney and then use the escape basket to try to reposition the stone. Now initially the stone was too big to reposition, so I had to use a laser in situ in the lower pole to kind of fragment it into maybe 3 pieces. And then I was able to reposition the 3 pieces even through the narrow infundibulum up to the upper pole. And what I always tell patients is if I can get the stone into the upper pole of the kidney, then I've sort of got a straight shot, and the upper pole of the kidney acts like a catcher's mitt. I'm able to run the scope right up to the stones, and then I can use the laser very effectively to do something called dusting. This particular case, the stone did dust partially, but also fragmented. Once you get the stone fragmented, sometimes you have fragments that are only maybe 1 or 2 millimeters. And I'm a big proponent of trying to extract those stones, and I think the OptiFlex is best suited for that. It maintains a pumpkin shape at sort of every millimeter size. Sometimes my staff make fun of me because we're pulling out 1, 2 millimeter stones, but I think if you're the patient, you really don't want to try to pass those fragments. And as much as you think they're going to pass, I mean, once you extract them with a basket, they're gone. So I will routinely use an access sheath, particularly on a secondary procedure. Sometimes we do these staged. And I'll use the OptiFlex basket to grab literally every piece of stone that's a millimeter or bigger and get it out and really render the patient stone free. I believe an end engaging basket is something that is certainly a very good option for repositioning stones. Once you reposition the stone and you've attempted to dust it, if you have fragments, I think the coda would be very nice to then be able to extract those fragments. So it's sort of a one basket that could do maybe multiple things rather than having to open multiple baskets. The results of the procedure were very good. She was rendered stone-free in one procedure. She had a stent for approximately 5 days. Her stent is out. She's been back for follow-up. She's had follow-up imaging that demonstrates that she's stone-free and no residual hydronephrosis or any other concerns. And now we've shifted our focus from the surgical management to the prevention, which is another thing I advocate for, is preventative care. One of the things that I think all of us strive for as physicians is to really put the patients in focus. I think if we put the patient care in focus, as I believe Boston Scientific does as a company, then I think we'll all end up where we need to be, which is providing better care. As we face challenges in this sort of next decade or so of medical care, we're going to face reimbursement challenges and other things. But I think if we can really focus on providing the best care at the lowest cost, I think that that's where we'll have a win for everybody, because ultimately these patients need the care and we need to figure out how to make it happen. So I think that's something that we can do as a partnership.